Hello, everyone, and welcome to our live session today. I will be going over a quick startup presentation to welcome you all and introduce you to our program and various opportunities. And if you've never attended our previous shadowing sessions, this will be a nice little informative presentation on how you can get involved or how you can also learn about other sessions going forward. So let me go ahead and share my slides. Hopefully you can see them all. So we do request that you mute yourself when you join our session, just so that you can ensure the professional has complete and full attention from the audience and that we don't pick up any of your background noise or comments that you might have. So I'd like to just start off by saying who we are. We are a student-led, minority-led, woman-led nonprofit dedicated to helping prospective healthcare professionals gain access to educational resources and materials that kind of help them get into the healthcare field. We do provide access to everyone, and we are always looking forward to improvements in our providing access to anyone that's of any demographic status or abilities or location. My name is Kira, and I am a volunteer at the Pre-Health Shadowing Company. And so I'd like to thank you all for attending. And so let's get started. So just to let you know, we do have closed captioning for all of our sessions to accommodate as many students as possible, and you can turn those on at the bottom of your screen. And this settings through Zoom, so sometimes they are great and sometimes they're not. So if you do need more assistance, feel free to email us at info@prehealthshadowing.com. We can always provide you with an email that has the transcript or help you out in any other way if you have trouble having any kind of access. And so if you want the transcript or anything that you think that could help us or benefit our program, that would be great. You can just email us. So we can be more inclusive for anyone that has any more accessible challenges. So if you want to stay in our loop, we do have an email list or through info@prehealthshadowing.com, but we also have Instagram, TikTok, and Twitter, which is X now. All of these have different resources or access to materials, even to the sessions. We do post ahead of time who's going to be lecturing and on what. And we also include some mini videos on kind of the people that are going to be presenting. I know today that we did. So if you want to go look through that, you can always see Dr. Ezra Cohen's little mini bio. So since this is an international program and we want to know where you're Zooming from today, you can drop it in the chat. I'm calling from California, Los Angeles to be specific. I know that Ezra Cohen is in San Diego, which is also kind of close by. I see a lot of people are in California, Massachusetts. We have quite a few people from New York, Ohio. Always kind of cool seeing everyone. We haven't had a lot of international people, but it's not a great time for them, I guess. Maybe we'll start trying to host meetings in the mornings. So if you're interested in being a part of pre-health shadowing and you're looking for additional ways to get involved, we do have volunteer and asynchronous volunteer opportunities. If you'd like to go to our website at prehealthshadowing.com, we're always looking for more ways to improve or more people to help us with our website or our posts. You don't necessarily have to do these sessions, although you can. Always a fun opportunity to kind of lead the chat or make up questions for the quizzes and those sorts of things. So if you want more information, you can visit our website underneath the blog section. And we have some wonderful opportunities and benefits from being in our program. So if you want to play a bigger part of that, we'd love for you to join our network of student volunteers and team members. And you can see various projects or lead initiatives or professional outreach, grant writing, more. That's kind of listed. So we do have a leadership program. If you want to join that, that is a few more hours during the week than volunteering. It is very flexible with your schedule and it is 100% remote, which is always a pro for everyone. So here's some of the leadership roles. that you can be a part of. We have IT department, grant writing, lead of fundraising, video productions, research programs, recruitment, diversity and inclusion, department lead head, and lead of volunteer communications. There's also more opportunities to do other things, and we always welcome people who have ideas for different leadership roles, maybe even ones that we haven't thought about. As part of our mission, we're trying to promote a difference in kind of age ranges and people in different parts of the situation. So we do have high school students availability for HTP, which is an offered leadership and healthcare education for pre-college learners. That is also on our website if you want to go learn more about that. It includes you can make clubs through your school or kind of help out our program and getting more access to students who might be in the pre-health field and want to be a part of that. That's only if you're in high school, of course, but we do have opportunities if you're not in high school and you're in the pre-health field to do the leadership roles. So let's talk about diversity because we're always looking for more diversity and to promote diversity and as a part of our mission. So in order to do this, we have launched an initiative to have monthly panels to celebrate different demographics in the field of medicine. So if you have a mentor or a teacher or a professional that has inspired you and thinks that can contribute to these conversations, you can always nominate them using the link in the chat. Or also, you can email us at info@prehealthshadowing.com and let us know who that professional is and how they have kind of contributed to your growth or your idea of inspiration. And we'd be happy to kind of reach out and see if they would be a valued part of our panels. So lastly, I'd like to say that we are a completely free program and we're completely student run. We work around the clock to make this free and accessible to everyone. Unfortunately, our website and our Zoom and everything is not completely free. So any kind of contribution is much appreciated. And so we humbly ask if you can donate, please do. The QR code is right there. You can also go to our website and donate directly through prehealthshadowing.com. And so if you cannot donate, even if it's a few dollars, we're always appreciative. You can always send that to anyone you think can donate or would love to kind of support our organization and providing more resources for pre-health students. So we do recommend that you drop your questions for the speaker in the chat and have our team members will be noting those down. So don't worry about asking questions and no one really noticing them. We will have them written down and then have during the Q&A, I can also ask those questions for you, or you can raise your hand and I will call on you and you can talk to the professional, Dr. Cohen, in person, or I guess through Zoom. So take good notes. As our professional is going to be going over their presentation, there will be a chance to take a post-shadowing assessment at the end of this session to verify your virtual shadowing hours and get your certificate. There's going to be more information toward the end of the video on how this is completed and what to do during that quiz. And lastly, if you can turn your cameras on, we always love seeing people's faces. And this is by no means an obligation as we're respectful for everyone's circumstances, but it does help us feel closer as a little community. So now I'd like to introduce Dr. Ezra Cohen. He's a medical oncologist and internationally recognized cancer researcher. So to start, I'd love to share Dr. Cohen's favorite quote, "Luck is the residue of design." It's by Branch Rickey, and he says that we are only lucky or successful if we set ourselves up to be. It is not something that happens by chance, or not always. So now, with great appreciation, I'd like to welcome Dr. Ezra Cohen and say thank you so much for joining today. And if you can share your screen, that would be great whenever you're ready.
But we worked very much as a team. Every person pictured here had their role. They did it well, and arguably we were one of the best head and neck cancer teams in the world. The other thing to take away from this picture is mentorship. I was a junior faculty member when this picture was taken. I had hair back then, and I'm on the far right of this picture. But the person without so much hair that's pictured on the far left is Everett Vokes, and it really I got lucky. But I also found myself in a high level institution realizing that mentorship was going to be important. But I was lucky enough to find Everett Vokes, and he became my mentor and really opened up incredible opportunities for me that I can safely say I would not be in the position I am now without his mentorship. So things were going incredibly well for us at the University of Chicago. We were publishing papers in the laboratory looking at the basic biology of head and neck cancer and signaling pathways. I had a laboratory that studied specific types of signals in cancer cells. We studied biomarkers that drove cancer, and then some other scientific directions that looked at how cancer cells recycle their proteins and how they um, go about their day-to-day lives, if you will, in a process called autophagy. And things were going very well in the laboratory. In addition, we were publishing incredibly impactful clinical papers in head and neck cancer and really driving part of the standard of care in this field, not only in patients who had metastatic or refractory disease, but also in patients who had locally advanced disease and were being treated for cure. And these are some papers that really drove the field and drove the standard of care among these patients. Um, but then an opportunity came up. And not that opportunities hadn't come up when I was at the University of Chicago. I was there for about 15 years. And as is typical of most faculty members in most academic institutions, every once in a while you get asked if you're willing or ready to move, or if you're interested in exploring a new opportunity, whatever that might be. And I was no exception to that. I certainly had opportunities to pursue, and in fact, even visited some centers, even more than once, with the thought that this may be the next step in my career. But time after time, I realized that what I had with the team and the opportunities at the University of Chicago were inevitably better. And I decided to decline those offers and continue pursuing what we were doing in Chicago until the time came to think otherwise. And that was when I was approached by a gentleman named Scott Lippman at the University of California, San Diego. And here you see at the top is Moore's Cancer Center. So that's our cancer center. And at the bottom are fish tacos and famous Scripps Pier. And I distinctly remember coming to San Diego to look at the opportunity. And many of my colleagues, and by the way, I came in November thinking, remember I was coming from Chicago, thinking, well, I'm never going to go to San Diego because I really am enjoying what I'm doing in Chicago and we're doing high quality work, but it won't be so bad to spend a winter weekend in San Diego and enjoy some good weather for a little while. But what I ended up leaving with was a sense that um, the things that were happening at UCSD and, in fact, in San Diego in general, were going to change the world. That I remember that distinct feeling as I walked out after the second day of meeting people and walked out that door that you see pictured there, and truly thinking that there were things going on in this community scientifically that were not happening anywhere else in the world. And once I thought that, the path was clear. And so the lesson to take away from this is know when the time comes and when the right opportunity comes, for you to make that change. And that will happen throughout your life and throughout your career. It happened to me when I transitioned from family medicine to oncology, and then it happened again when I left the University of Chicago to come to UCSD. And I was fortunate also to meet this couple. Um, the gentleman pictured on the left is Ralph Whitworth, who unfortunately was diagnosed with metastatic head and neck cancer. And interestingly, I'll tell you a couple of stories about Ralph and my interactions with him. He called me when I was still in Chicago, and he said, sort of cold called me and said, my doctors have recommended that I talk to you, that you're a leader in the field. And here's my situation. I've got this cancer that has spread to my lungs, and I'm looking for opportunities. And we spoke for about an hour and talked about what was going on in the field, what was going on in research, what the options were for treating his cancer. Fortunately, he was still feeling very good, very healthy, and the cancer was still fairly low volume. And at the end of that phone call, he said, "Well, you know what? I want to come see you. How do I get in to see you? Do I need to come to Chicago?" And I said, "Well, actually, you don't need to come to Chicago because in 2 weeks I'm moving to San Diego to join the faculty at the University of California, San Diego." And he said, "Oh, that's interesting. I live in San Diego." And so that was a nice coincidence, and perhaps a little bit lucky in retrospect to have met at that time in both our lives. And then about a month after that, or maybe about 2 months after that, after having arrived in San Diego and now began to establish myself as a faculty member, Ralph and I had a coffee at the cafe at the Cancer Center, and we began talking about opportunities and research and again getting deep into what was happening in the field. And Ralph asked me a very simple question: what do we need to make this happen? What do we need to accelerate this research? And I looked at him point blank, and I said, not knowing what his financial situation was, and I said, "Ralph, quite honestly, we need money. I can do all the things that I just talked to you about, but we need resources, and that's why things are moving so slowly." And his response to that was, "I think I can do something about that." What I didn't know at the time is Ralph Whitworth is a billionaire, or was a billionaire. He had just left as chairman of the board of a company called Hewlett Packard, who some of you have probably heard of if you use printers. I don't know if anybody uses printers anymore, but anyway. So indeed, he could make that happen, and through a foundation that he established called the Immunotherapy Foundation, we basically built a cancer immunotherapy program at the University of California, San Diego, that included building a facility to manufacture cell therapy products, multiple clinical trials, and multiple research labs that were all studying immunotherapy in cancer to move the field forward as fast as we possibly could. And to give you an example of that and the impact of what an individual or a group of individuals could do at the right time, let me tell you another story. And that's a story of this gentleman um, who was diagnosed with tongue cancer and treated in an attempt to cure the cancer. I'm going to guess many of you in this audience aren't used to looking at PET scans, so let me orient you a little bit. Um, Actually, it'd be easier if I had a pointer, which is right here. So let me do that. You can see a pointer now, I think. Okay. So what I'm pointing to is his jaw, his mandible. This is his vertebral column, or the cervical spine. And when we do a PET scan picks up tissues that use high rates of glucose. And that glucose is used because those cells are very active and usually actively dividing. And the reason a PET scan is useful in cancer is because cancer cells divide much more rapidly than normal cells and therefore utilize a lot more glucose than normal cells. In fact, a PET scan isn't very good at looking at the brain because the brain cells also use a lot of cancer and the brain lights up normally. But tissues like muscles here or bone, they don't use a lot of glucose on a regular basis, and so they don't light up on the PET scan. When we see things like this, like orange and yellow and red, we begin to worry because those often represent cancer. And that's exactly what we're seeing here. This gentleman had a cancer in his tongue, in the back of his tongue, and he had an adjacent lymph node in his neck. Now, this looks bad, and in many ways it is, but for patients in his situation, we can use chemotherapy and radiation. And for the great majority of those patients, believe it or not, about 70 or 80%, we end up curing them. And when we do a PET scan at the end of treatment, what we expect to see is no more orange, red, or yellow. We expect to see a clear scan because the treatment has worked and the patient is on his way or her way to being cured. Oops, I cannot use the pointer. Same time, sorry. But the problem with this gentleman is that this is his PET scan after treatment. So, despite the fact that we were trying to cure this gentleman, not only did we not, or did the treating center not cure his cancer actually grew after treatment. Now it involves almost the entirety of his tongue. You can see the yellow there. And now it involves lymph nodes on both sides of his neck. The standard therapy for a person in this situation is a surgery called a total glossectomy and pharyngectomy. And that's exactly what he was offered. The surgery involves taking out his entire tongue and his entire throat. He would never be able to eat again. He'd never be able to speak again. He'd never be able to swallow again. And think about everything that we do and everything that defines us as human beings that occurs above the clavicles and how important those things are to how we define ourselves and how we interact socially. He would never be able to do that again. And because of the job that he did, his occupation, I'll show you that in just a minute, he said to his oncologist, there's no way I'm doing that surgery. Oh, and I should also point out that that surgery only has a 10% success rate in terms of curing the cancer. So not only is it an awful thing to go through, but the chances of it actually curing the cancer are 10% or less. So he said, I'm not doing it. I'd rather die than have that surgery. And is there anything else that you would consider? And his oncologist, who's a friend of mine, he was being seen in the Los Angeles area, said, well, they're doing some innovative work with immunotherapy down at UCSD. This was now about 2 years after I had that conversation in the cafe with Ralph Whitworth. So we were able to start building the immunotherapy program. Why don't you go see my colleague, Dr. Cohen, and see what they have going on? And sure enough, he came down and came down for a visit, and we spoke for a while. And we started him on a clinical trial of immunotherapy. And about 2 weeks after, sorry, about 4 weeks after he started that trial, he gave me a call and he said, Dr. Cohen, I think something's terribly wrong. I'm in more pain. I'm not swallowing solid food anymore, and I think the tumor is growing. And I said, well, hold on, Ricky. This is way too fast for this to be cancer progression. This may be exactly what we want with immunotherapy. And what we might be seeing is your immune system responding to the cancer. I said, I'm going to give you some more pain medicine. You can go on a fully liquid diet as long as you're swallowing. And if you stop breathing, call 911. About 4 weeks after that, he called me and he said, Dr. Cohen, I haven't taken pain medicine for a week. I'm eating better now than I have in more than a year. And I think I just coughed up my tumor. And this was his PET scan about 9 weeks after starting treatment. And you can see, I think you can readily appreciate that that area of yellow is a lot smaller than it was before. And you know what? I think he really did cough up his tumor. He's now not on any pain medicine, and his swallowing has significantly improved. And I'll draw your attention to the date of this PET scan. It is May of 2016. This is his PET scan 2 months after, now July of 2016, and there's no more cancer. This is a gentleman who was faced with a life-threatening, imminently life-threatening situation. And now, just a few months after that, there's no evidence of cancer with immunotherapy. The gentleman happens to be Ricky Rocket. I'm going to guess most of you have not heard of a band, a heavy metal band back in the 80s called Poison. Maybe they're making a comeback. I don't know. But Ricky Rocket started Poison with his friend Brett Michaels. He's now, this was from People Magazine, probably my best cited article. And I'm happy to say that just a couple of years ago, they actually went on tour, including playing down here at Petco Park. And so not only is he cancer free, and he, by the way, he still remains cancer free now a decade later, but he's able to do everything that he wants, including going back on tour with his band. And that's really the power of what we can do for immunotherapy, with immunotherapy, sorry, and part of the reason that I got into oncology in the first place. But let me make another point here in terms of lessons learned. And the lesson that I'm going to tell you about next is be bold. Because we don't, we won't get places fast enough. We won't make advances fast enough if we're not bold and if we're afraid to make mistakes. Don't be afraid to make mistakes and think um, courageously. And um, I was able to do that with a colleague, Stephen Schoenberger, and we began talking about what we need to do in cancer to really take a leap forward with immunotherapy. And as we began to talk about this back and forth over a few meetings, we realized a few things, or a few things came together at once. At that point, sequencing of the genome, and especially the cancer genome, was fairly routine. And as we were sequencing more and more cancer genomes, we were understanding that no two cancers are the same. So, two patients may be diagnosed with breast cancer, but when you look at the genes that are driving that breast cancer, and more importantly, the mutations that are driving that breast cancer, they're completely different. There are no two cancers that have the same mutational profile. So, in a sense, every cancer is unique. And then, if you think about the immune system, everybody's immune system is unique. You may be exposed to a virus and you just go about your regular day and your immune system fights off that virus and you never get sick. While the person next to you gets exposed to the exact same virus and they're, laid up in bed for a week. And that's the difference in how an immune system responds to an antigen or a pathogen. And so we put those two critical pieces of knowledge together and we hypothesized that if everybody's cancer is different and everybody's immune system is different, then if we could find a way to identify what it is in the cancer that that individual's immune system is responding to, and then we could turn that into a therapy, well, we would have a major step forward in cancer therapy. And that's exactly what we undertook about a decade ago, a little bit less than a decade ago, and decided to create a cancer vaccine that was going to apply to only one person in the world. So rather than make drugs that would treat thousands, tens of thousands, or hundreds of thousands of people, the idea that every cancer is unique told us that we need to develop therapies for each individual, one at a time. And we're happy that we found that way. We found a methodology that, and I'll show you about that in just a second, that identifies these neoantigens. So antigens are what the immune system responds to. Neo is new, and neoantigens derive from the mutations in a cancer. Cancer is driven by these mutations. Every cancer has mutations. And so now, in a sense, we've found the Achilles heel of cancer. They have to have mutations. Those mutations are unique to that individual. And if we found a way to identify how the immune system was responding, we could galvanize that response. And so in October of 2018, we treated our first patient. Her name is Tamara Strauss. That's her mother standing behind her. One of my colleagues is standing, Aaron Miller, and the person kneeling next to Tamara is my other colleague, Stephen Schoenberger. And there I am administering the first dose of this personalized neoantigen vaccine. Incidentally, I hadn't given a intramuscular injection in about 20 years. So literally, I had to YouTube how to give an intramuscular injection. I didn't tell Tamara that, so keep that between us. But here's what we did. We took a patient's tumor and their blood, and we sequenced that tumor so we could understand what mutations were being expressed. And then we developed a variant caller, basically an algorithm, to identify the expressed tumor mutations in that sequencing. Because if a mutation is not expressed, it can't be presented to the immune system. We then developed our own algorithm to prioritize the immunogenic mutations. And we did this iteratively with every patient learning from every single patient that we did. And now we've done about close to 500 patients, taking them through this. And what we were able to do is distribute the mutations at 4 levels. These are all mutations that are expressed in the cancer. And the level 4 mutations were the most immunogenic. That is what we thought the immune system would see most easily. And it turns out that we were right about 40% of the time, that about 40% of these level 4 mutations were indeed seen by the immune system. And how do we know that? Well, we knew that because we took the patient's blood, we extracted their T cells, and we tested those T cells against peptides that represented the mutations. And so we weren't guessing what the immune system was responding to. We were letting that person's immune system tell us, what are you seeing? What are your T cells seeing in the cancer? And then we could turn those same peptides that their T cells recognized into a vaccine. And in fact, what we saw, now we have actually, that number needs to be updated. It's about over 500 patients. And we saw this in every cancer we looked at. Even cancers like glioblastoma, that's a type of brain cancer, or parotid cancers that were thought to be non-immunogenic, that the immune system didn't respond to these cancers. Well, it turns out that every person we looked at had T cells circulating in their blood that could recognize mutations in their cancer. And sure enough, we saw cancer shrink. This is the same patient that was pictured in that article. This is Tamara Strauss's tumor. You can see a tumor in her liver, it's circled. The tumor gets smaller after the first few doses of the vaccine, and it gets even progressively smaller after the 6th dose of the vaccine. And believe it or not, she had had immunotherapy before. All we were adding now was the vaccine. And here's the table that really told us we were on the right track. It's a little bit complicated, so give me a second to take you through it. If you're following everything I've said so far, okay, we developed a way to identify neoantigens, so what T cells were responding to. We developed a vaccine to stimulate those T cells. And if those T cells were indeed being stimulated and were beginning to proliferate, they should be able to get to the tumor and they should be able to eliminate the cancer cells that express the mutation that they see, because that's what T cells do. They interact with a receptor that represents the mutation on a cancer cell. And if they see that, that T cell will destroy that cancer cell. And that's exactly what we saw in 80% of the patients that we treated. If you look at these columns, the target mutation was disappearing in the DNA and the RNA of the cancer, while the non-target mutations, so mutations that weren't in the vaccine, we weren't touching those at all. So what this told us is that, in fact, we were doing exactly what we wanted to do. We were producing a specific T cell response that was targeting the mutations in that person's cancer that the T cells could see, the immunogenic neoantigens. So again, I go back to the team. There's no way I could have done all of this without an incredible team. And there's Stephen and Aaron pictured at the top. But again, every single person pictured here had their expertise and their specific role that they brought to this project. But then something else happened. And this is the last story I'll tell you. We were Things were going great. We were getting grants. We were publishing papers. Very satisfied with the work that we were doing. But then somebody named Eric Letovsky approached me. This is now about 2.5 years ago, and he said, "There's a company called Tempus, and Tempus I'd known about for a while because I was using their products and I was consulting for them." And the chief medical officer position just opened up at my company. Would you be interested in taking a look? And at first I thought, well, all right, I'll take a look, but I'm not that keen on moving, and I really enjoy what I'm doing. But then as I took a look at what Tempest was doing, I began to understand that once again, I could have an impact in that role that I could never have on a global scale. So not affecting hundreds or even 1,000 patients, but now influencing the course of disease in hundreds of thousands to even millions of patients. And that's when I made another change because the impact is going to be tremendous, and became the chief medical officer of this company called Tempus, or Tempus AI. And what Tempus AI is really trying to do is now bring the power of artificial intelligence. And of course, that means many different things to many different people. But what I mean in this case is large language models and computing to be able to now extract information from the data that we could never do before. And the reason, oops, that was misplaced. And the reason funny story. So 3 days after I joined the company, I was asked to give a talk at at our major meeting, the American Society of Clinical Oncology. So sometimes when you make a change, you get thrown right into the fire. So just be aware of that. But the point I'm trying to make is that uh, at Tempest, what we were able to do, sorry, so why Tempest? What we were able to do is, and this is really the secret sauce, and what got me captivated, was that we were able to, and we are able to take different types of data, so multimodal data, and using computational programs and large language models, integrate all that multimodal data and begin to produce insights that the world truly had never seen. And those are insights to providers that were treating patients. Those were insights to AI programs, and those were insights to pharmaceutical companies to make drug development more efficient. And the reason we could do that is because Tempus has amassed the largest database in existence in oncology. It is now about 200, so this needs to be updated. It's now 250 petabytes of data. I didn't know what a petabyte was when I went to Tempus. A petabyte is 1,000 terabytes, and a terabyte is 1,000 gigabytes. So think about how large that data set is. It's now about 8 million patients. And with that type of data and the computing power that we have, we can begin to answer questions and test hypotheses that were never before possible, and even, I dare say, never before imaginable. And now what we're able to do is take the genomics, so the sequencing, take the data, and take the AI power and develop analytics, diagnostics, and other applications that help patients every single day in every situation that they're faced with. Um, and those applications can look like a program that we call Next that alerts providers when a patient that they're seeing should get a specific type of test or a specific type of treatment based on published guidelines and published literature. Pixel that helps radiologists identify nodules in somebody's lung and reminds that provider that, hey, there's a nodule in this person's CT scan that is growing, and you should probably take a look at that so that people don't end up with advanced non-small cell lung cancer. A program called Lens, where we've made these 8 million patients worth of data available to the public and to researchers because we don't have all the answers and we can't ask all the questions, but we want those hypotheses tested as rapidly as possible. And so it really becomes about putting the right patient at the right time with the right therapy. And when we do that, we drive better outcomes. And what's very satisfying for me is that we're driving those outcomes in a life-threatening disease, cancer. So let me leave you with a couple of slides, and I think we have time for questions afterwards. And the first is some philosophies that I've put together over the years. And the first thing is, and this is what I tell my organization, this is what I tell people I work with. And so indulge me for a couple of minutes, if you will. There are no bad ideas, and everyone provides input. It doesn't matter if you are a senior vice president or if you are just starting at our company. I say the same thing to every individual. Because believe it or not, those people at the lowest point in the organizational chart often have the most to contribute. And they have the most to contribute because they're thinking about the problems in a fresh way. And they've come with a background that's likely significantly different than what I have and what more senior people have. Seek collaborations. I think I've given you multiple examples where a team approach, when you can work with incredibly smart people and work hard, great things happen. Never be afraid to fail, but learn from your mistakes. If we're afraid to fail, we will get nowhere. I have failed many, many more times than I have succeeded. But every single time we failed, we learn. And that's the key. Discomfort is good. Don't get comfortable in what you're doing. The best things happen when you're a little bit uncomfortable. Don't be miserable, but be a little bit uncomfortable. And the best science happens when people are at the edges of their comfort zone. Imagination always wins. Be creative, think big, be bold. Be bold is the next one. And then build for the future. Don't build for yesterday. It's gone. All we have to work for is what's ahead of us. So don't commiserate about what's happened and I should have done this or I wish I would have done that. You're in a specific situation and you can only think about how what you do now affects what will happen tomorrow. And then lastly, never accept the status quo. If you're told something like cancer is not curable, cancer cannot be beaten, don't accept it. Because once we start to accept the status quo, we start to stop imagining and never stop imagining. Every cancer, in fact, can be beaten. That's my sincere belief. And I've shown you a couple of examples of how, in fact, that might be true. And I'll leave you with one last story. Um, the gentleman pictured in the middle, raising his wine glass, is Albert Kaufman, who's celebrating his 90th birthday. Some of you may be familiar with a reality show, Say Yes to the Dress. It's a show where brides come and look at their wedding gowns. Well, he was the accountant for that shop, and his brother was the person who started it. Um, so he lived in New York, and a few years before this picture was taken, years before this picture was taken, he unfortunately had a tongue cancer that kept coming back. And every time it would come back, it would be worse. To the point where his oncologist in New York told him that there was nothing else that they could offer him and that he should go into hospice. He should get end of life care. And his response to them was, "Well, okay, I'm 87 years old, 80 about to turn 87 years old. He was 86 at the time. I've lived a great life. My kids all live in San Diego. I'm going to move to San Diego, and I'm going to live out the last few months of my life with surrounded by family. And do you know an oncologist in San Diego that I could see and could help me through this?" And they referred him to me. And the first time I saw him, I said, "Look, I'm not proposing that we do anything radical for your cancer. I understand the situation, but you know what? Let's get at least some more information about your cancer. Let's sequence your cancer. Let's understand something about the molecular biology because that hadn't been done. And if it is appropriate, maybe we should consider immunotherapy because, in all likelihood, it won't cause very many side effects. And who knows, it might just work." Well, it turns out that his cancer overexpressed a gene called PDL1, and it overexpressed that gene 100-fold more than normal. And for cancers that have overexpression of that gene, their response rate to immunotherapy is about 80%. So instead of the usual 20% that we expect, for PDL1 amplified tumors, that's the gene PDL1, the response rate was incredibly high. So naturally, we got excited. We started him on an immunotherapy drug, and 3.5 years later, he was celebrating his 90th birthday with no evidence of cancer. And I'll leave you with that story because it really goes back to everything I've said for the last 45 minutes or so. Be bold, use your imagination, don't be afraid to fail, and dream. Don't be afraid to dream. And those dreams do come true. Thank you very much, Kira, for the invitation. Thanks, guys, for listening to me for for 45 minutes or so. And I'll be happy to take questions.
Thank you so much for all that information. I'm sure everyone loved your presentation. I know I did. So a few of the questions here, one of them is from Catherine. Um, she's more medical college question, but she said, I'm currently a college first year and struggling a bit figuring out how to finance my education and satisfy a lot of the pre-med requirements, like clinical hours and volunteering, so more extracurriculars. She was wondering if you had any tips on extracurriculars or in that regard.
Yeah. So I'll first say, I was fortunate that I grew up in Canada, and so to put things into perspective, um, I remember when I was at the University of Toronto, we protested at the university because our tuition for a year of medical school was going from $2,000 to $2,200. And we literally protested on the main lawn of the university. Things have changed, and especially in the United States, where medical education can run you $250,000 in tuition, let alone all the other costs that are associated with it. Fortunately, there are many schools that offer assistance, and of course, there's a loan program in the U.S. But I empathize. Medical education is unfortunately incredibly expensive. I think that's a flaw in our system. I think what it creates is uh, a a situation where we're not getting the best people in the field. And because people that get into medical school have so much pressure to pay back their loans, they can't necessarily pursue um, certain fields in medicine that maybe don't pay so well. So I'll get off my soapbox. I don't have a solution for that. But to answer the second part of your question, I think the most important thing, and I was told this actually when I was before medical school, when I was in a situation exactly like yours. Um, do what you like. Find something that you like to do and enjoy it. You'll get much more out of the experience, and you'll end up growing as an individual and as a human being versus being in a situation that you really don't enjoy. Now, if something you like has something to do with the medical field, that's even better. There are many opportunities. Unfortunately, don't expect to get paid for many of them, or certainly don't expect to get paid highly for many of them. But don't be afraid to ask. Ask your professors. Even ask your doctor. Ask your doctor's friends. And don't be afraid to cold call people. I get emails all the time, and in fact, on February, the first Monday in February, I got an email out of the blue from a student who just wanted to shadow, and she's going to be shadowing me the first Monday of February for a couple of months. I don't know who she is. I have no idea. I've never met her before, but you know what? I'm in clinic anyway, and if she wants to tag along and learn a few things along the way, why not? And so don't be afraid to ask. Don't be afraid to do that. But most importantly, do something that you like.
Awesome. That was a great answer. So Lavasha is our next one. She says, who qualifies for your specialized vaccine and what medical insurance are accepted for that?
Yeah, so we were fortunate. Let me answer the second part first. We were fortunate to be able to do this under a clinical trial that was funded. And so everything was covered. The patient bore no expense. And what I didn't mention is that because we are creating this vaccine, this vaccine for only one person on Earth, it's not cheap, unfortunately. The entire process is anywhere from 150 to $200,000 to get from sequencing the tumor to actually injecting the vaccine product into somebody's arm. Now, putting that into perspective, a year of conventional immunotherapy is about twice that. A cell therapy, an approved cell therapy is about three times that. But still, I appreciate that $150,000 is a lot of money. We are able now to bring those costs down with properties of scale and more efficient manufacturing. But unfortunately, it's never going to be $1,000. Well, who knows? We never thought we'd sequence a genome for a couple of $100. So maybe one day, but right now it's expensive. But for right now, the patients have borne none of the cost. Who qualifies? Um, if you think about what I said, the answer is everybody. And what I mean by that is, remember, cancer is a disease of mutations. Every cancer has mutations. It has to have mutations in order to have a growth advantage over normal cells. And everybody's immune system will respond to some aspect of those mutations. And so, in reality, this is a treatment that could be offered for any cancer in any individual. Now, of course, under a clinical trial, there's a list of eligibility criteria because at the end of the day, it is still an experiment and we're testing a hypothesis. But what I'd love to see one day, as this goes forward and advances, that this becomes part of the therapy for everybody with cancer.
And then Folarine messaged and said, how did you identify which organs you wanted to focus on when you're going into medical oncology?
Which organs or which organ? Did you say organs?
She did say organs, but
Yeah. It's interesting that you phrased it that way because traditionally medicine has been a disease, an anatomic disease. We've approached it in that way, as you said, organs. So you have specialists that study the heart or the brain or the liver, and that of course comes from days where that's what we had, that's what we knew. We didn't understand that a disease of the cardiovascular system may have a lot in common with a disease of the kidneys at a molecular level. We're beginning to understand those things a lot more, and fields like rheumatology and oncology have sprung up because there's commonalities. And from a personal note, one of the reasons I went into oncology is that it didn't focus on a single organ, it focused on the entire patient. And what we try to do with oncology is have that whole patient have a better outcome, not just their heart or their liver. And that holistic approach is one of the satisfying things about being an oncologist. That personally, that's the reason. That's one of the reasons I went into cancer.
I was also curious about that, so I'm glad you asked for Lorraine. Mindy asked, do you feel there's a challenge in making such innovation accessible to everyone, especially with underserved communities, when it comes to personalized medicine?
Yes, there is a tremendous challenge. We have to understand that we live in a very privileged society, and I know that not everybody enjoys that privilege, but most of us in the U.S. and when I say most, I'm talking about easily 80% enjoy a privilege in medical care that is not found in the most of the world. Um, Now, unfortunately, there's still a large population of the US that doesn't enjoy that, and we need to address that as well. But the global problem is much, much larger. And we think about this all the time. In fact, one of the reasons I went to Tempus was exactly that, that we could develop tools that were inexpensive, that were easily deployed, and didn't require a lot of money, didn't require sophisticated systems, and could help patients irrespective of what system they were in or where they lived. We're not there yet. We have a long way to go to get there, but at least the tools that we're developing, some of them, not all of them, but some of them meet those criteria. And in fact, the most impactful ones meet those criteria. Our hope is that we'll live in a world where it doesn't matter where you're born, you still have access to high quality care.
She also asked us another question, for are there any limitations or challenges when it comes to immunotherapy against cancers?
There are. The biggest one is still understanding the immune system. The immunotherapy is not a new concept. Actually is more than 100 years old. The first immunotherapy used on a patient um, was derived by a surgeon working at a cancer center called Memorial Sloan Kettering in New York City. He was a sarcoma surgeon, and he had a patient who had a very bad sarcoma and was dying of the cancer. But at some point in his course, that patient got a very bad skin infection. Now, 100 years ago, there wasn't antibiotics. So if you had an infection like that, most often you died. But somehow this patient survived the infection and the cancer went away. The cancer went into complete remission. And so the surgeon, this was the genius of it, his name was Cooley, um, hypothesized that whatever whatever his body did to eliminate the infection worked also against the cancer. And so he thought, well, that what could it be? That had to be some component of the immune system. He had an immune response against the infection, and he had an immune response against the cancer, and those paralleled each other. And so, believe it or not, he created a drug called Cooley's toxin that was basically derived from bacteria. He would give patients a low-level infection in the hopes that their immune system would activate against their cancer. And here's the great part. Cooley's toxin was FDA approved. It was approved in this country until 1963. But the point of the story is the immune system is incredibly complex. And so the biggest challenge that we've had is understanding that immune system. And there were discoveries about how antigens are presented and different types of cells and how T cells work and how the interplay between all the different cells in the immune system work to create really an anti-pathogen response. Because remember, the immune system wasn't designed to fight cancer, it was designed to fight viruses and bacteria, but how that immune response can be used against cancer. And there are, of course, other challenges. There are some patients who unfortunately have another disease, an autoimmune disease, where their immune system is actually working against their normal cells. And I'm sure most of you have heard of some of these diseases: rheumatoid arthritis, Crohn's disease. There's a very long list. For those patients, it can be dangerous to give them certain types of immunotherapy because ramping up their immune system could really activate their autoimmune disease. And then there is a challenge of cost right now for immunotherapy. Immunotherapies are expensive. I had a colleague of mine who did a 3 month uh, I guess sabbatical in Rwanda, and they don't have immunotherapy there at all. In fact, he came back and he said they struggle to get chemotherapies that we've had for 30 years to treat their patients. Immunotherapy is like a dream. They're not even close to being able to afford those types of treatments. So getting back to what one of the earlier questions was as well.
Reminds me of the story of the start of penicillin.
Yeah,
I'll have to
yeah,
look up the toxin though. That sounds pretty interesting.
yeah,
And then Folorine also asked, how'd you identify your mentor in Chicago? So do you have any suggestions on
yeah,
identifying mentors for
yeah.
future students?
So I got lucky. So again, we come back to that concept of luck is the residue of design. So I was fortunate to be at a good institution. But beyond all that, I think there's a few things that you should look for in a mentor. First, it should be somebody that you get along with. So if if you can't see yourself being friends with this person, and of course you're not going to have that type of relationship, you're going to be mentor mentee. But if you can't have a conversation with this person, if you don't like them, that relationship isn't going to work. Second, it should be somebody who has experience mentoring. And when you look for a mentor, don't be afraid to ask them that, because this is your future. Tell me about who you've mentored. Who have you had in your laboratory? Who have you had in your clinic? Who have tell me about other people that you've worked with. Um, and then lastly, they should be able to open up opportunities for you. And there's two aspects to that, two very important aspects, and they have to do with the last two elements that I just told you. One aspect is they have to be willing to open up those opportunities. And I see, unfortunately, a lot of people, especially in academics, who just don't have that mindset. And remember, it's a very competitive environment, and you're really scored by what you have your name on and what you've published. And there are a lot of people, even in senior positions, that can never let that go. And they still have to claim ownership of the products that even their mentees and their trainees have done. Personally, I think that's terrible. I think that's wrong, but that's a mentor you want to stay away from. And then the other, of course, is they have to be in a position not only to want to open up those opportunities, but have those opportunities to open up. And that usually comes with a degree of seniority. So hopefully they go hand in hand as we become more senior investigators and get more experience. I don't want to write another paper. I have enough. I give that opportunity to a junior person and they get the credit. That's the type of person that you should be looking for. I hope that answered the question.
I think it answered it beautifully. And then there's another question from Rihanna. We have time for a few more questions, just so everybody knows. So it says, how readily available do you think the use of AI is in hospitals or pharmaceutical
Yeah.
companies? And also on that is Tempest partnered with any specific companies or hospitals that use their programs that are available for physicians?
Yeah, it's been the uptake has been slow, as many things in medicine are. Medicine does tend to be a conservative um, uh, uh, enterprise, and we doctors tend not to be early adapters. Um, but having said that, Tempus is connected. By connected, I mean we're integrated into the electronic medical record of now about 65% of the hospitals and medical practices in this country, where we're deploying those tools on a regular basis. So it took 9 years to get there, and so this didn't happen overnight. But now we're at a point where a lot of day-to-day activities in practice are being run that a provider is working with an AI agent to perform it. But we are at the oh, and by the way, we work with most of about 19 out of 20 of the largest pharmaceutical companies in the world, and many small biotechs. Again, providing AI services to help on the drug development side. But um, uh, but we're at the tip of the iceberg, or we're really AI is in its infancy. You guys will grow up in the not too distant future. Actually, I will see it where AI has an impact on every part of the doctor visit. So patients are going to be better informed because they're going to have the tools to ask and answer the most important questions that are relevant to them, that is specific to their medical history, their medical record, the drugs that they're taking, and the current condition of whatever problem they're addressing. They'll be able to ask the AI questions before they get to their provider. When they get to the provider, the AI will help them in that interaction. The AI will help the physician prepare for the visit because the AI will alert that physician to the guidelines, the literature, any drug-drug interactions, any things that are pertinent to that specific patient that they're about to go see. The AI will record the visit so that every aspect of that information exchange is captured. And then the AI will interpret the visit so that the most relevant factors that need to be maintained going forward become clear and present to both the provider and the patient. And then any testing that's done is going to be essentially not only ordered by the AI, that's fairly simple, but interpreted, helped to interpret and done so in a much more sophisticated and exact way than we're able to do as humans. So we are right at the beginning of what really is the third iteration of AI, but it's an incredibly exciting time. Surgeries are going to be done by AI, where the surgeon doesn't actually actively do the operation anymore, but just stands back and lets the AI do it because they're better. I hate to say it.
They're going to take over someday.
Yeah, we will be slaves to the machine, but well, I'll be dead by then. You guys might be.
Okay, I probably have time for two more questions. And they're kind of easier to answer questions, I think, because we have had a lot of content heavy questions, which I love. So Sasa asked if you had any suggestions for types of shadowing or volunteer work that kind of make you stand out as an applicant,
Yeah.
in terms of extracurricular.
Yeah, honestly, so the things that will help you stand out are either ones that demonstrate a degree of altruism or a degree of scientific interest. And if you can combine the two, that's even better. But again, I'll go back to what I said before. Please make sure it's something that you enjoy. Don't just do it for the sake of doing it. I spent a summer operating on dogs in the laboratory of a vascular surgeon. I hated it. I hated every moment of it, and it was a miserable summer. The next summer, my mentor at the time said, "You know what? Don't work in a lab. Go travel Europe. This is going to be your last summer before if you get into medical school next year." And that was the best decision I ever made. And I have many more positive memories from that than I do from working in the dog laboratory. Um, but if you can find opportunities that demonstrate an interest in science, that's great. And if you can find opportunities that demonstrate that you're interested in helping people, that's also great. Those are the two things I can tell you that when I used to do admissions for medical school, that's what we would look for.
Yes.
We want well-rounded people. So people who have hobbies, people who have other interests are much more likely to be physicians who interact with their patients. And so we look for those things.
Definitely, I definitely agree with that. Last question before we kind of get things wrapped up is Zane asked if there's ever been any times where he specifically said ED physicians, but any physicians have asked you to come and consult on a patient with cancer and what that process kind of looks like if you've ever done that.
Yeah, that's sort of my job. So yeah. So what'll often happen, yeah, unfortunately, is that sometimes a complication happens. Sometimes there's the cancer is not well controlled, and cancer patients can be in pain or they can get infections, and then they'll present to the emergency room because they're in distress. Usually when a cancer patient goes to the emergency room, they're going to be seen by an oncologist. Because although emergency docs, and by the way, I was an emergency physician for 4 years in that small town. They know a ton and they're wonderful physicians. They can't know everything, and they'll often consult an oncologist for what to do with this patient. That's basically the process. The emergency staff will assess the patient. They'll try to find out what's going on. They'll often call us and say, "Hey, this is the situation. What test do you think we should order? What would you like to do? And when you get a chance, can you come see this patient?"
That makes sense. Well, again, I'd like to say thank you so much for your presentation and taking the time to come talk to everyone, and answer all of our questions. And I know a lot of people are saying thank you in the chat. You can always go and look at that. So if you wouldn't mind killing off your share, I'll share mine
Yeah,
now.
yeah. Sorry about that.
No worries. So we always like to encourage everyone to reflect on their session. So what you brought you
Hey,
here.
Kira, I'm going to sign off, by the way. I just want to say thank you again for the opportunity. And if you don't need me anymore, I'm gonna say good
We don't
night.
need you
And
anymore.
thank
You
you.
can sign off. Thank you so
Okay.
much again.
All right. Bye, guys. You've been a great group.
So, to finalize our kind of wrap up everything, we always tell people to reflect, maybe kind of some notes on on the session today. What brought you here? What are your major takeaways? What do you want to learn more about? You're always welcome to message us. We can always see if there's any way that we can get your more questions. I know we missed a few, over to the doctor and maybe get back to you on that. So we always ask you to do that. You don't need to send them, post them, do whatever. That's just on yours. So it's not required, and we just encourage them. If you'd want to share them, you can always share your insights on LinkedIn. We always have posts on there and as well as on Instagram. You're welcome to kind of post or share your involvement or what you thought about our session today or our video. And so sometimes we also take some of those reflections and we post them on the website or, recognize the people that took the effort to do that. So again, if you want to learn more about us or get involved with our program, there's should be some links in the chat. I know that Sven's been kind of posting those. So that if you want to click on that, you can also go and visit our website at prehealthshadowing.com. And you can kind of learn more on being an asynchronous volunteer. That's something that I do. You can host the chat. You can help out with our Zoom sessions, but you can also just help out with the website, creating content, things like that. And then this is also counts as you'd get certified hours through professional nominations or graphic design or social media promotion. We're happy to kind of see where you guys fit and what your skills are that kind of offer that. And you can always join our team members and applications list for lead projects and initiatives. So lastly, once again, we do always ask that if you can donate, that you do donate. The QR code is right there. You can read that or you can scan that and see if, even if a few dollars helps us a lot. So if you don't have that, you can always message it to anyone else who's looking to kind of be more a part of our team. So now what we've been waiting for is how to get your digital certificate for attending. So to do that, you just go on the prehealthshadowing.com and you go to our website and you find the professionals course. That should be the course that you clicked on to start this session. And so there should be probably within the next 30 minutes. I think it's up now actually, but usually it's within the first hour of our session that we'll upload the recording, but we also upload the quiz. The quiz is timed at 30 minutes, but it's 10 questions. You have to get a 70% or higher. Pretty much if you've attended the session, you should be perfectly fine taking the quiz. I will not say that it's all too stressful or it's at all too challenging as long as you paid attention to the lecture. You should be fine. You're just going to take that for 30 minutes. You do get 2 attempts to take the quiz. So if something happens and it doesn't work out for you, you can always try again. And you can always message us if you have any technical difficulties. We are very happy to kind of work with you to see how you can get your certificate if you had some kind of mistake or you had some kind of technical difficulty during the quiz. So yeah, take the quiz. So if you missed any of the parts of session today, you can visit the YouTube channel. We will be posting this presentation. It will be within the next 24 hours, so don't expect to see it right now. And so if you missed any parts of the session or you want to just kind of fill in your notes or you want to just understand a little bit better what Dr. Cohen was saying, then you can go on there. You can rewatch this presentation. So if you guys need that, that's there. So next week we also have a session. It's not on this picture, but we do have another session next week. I believe it's next Tuesday, so if you can get onto that, that'd be great. We're always kind of sending these out. They'll be on our Instagram, our LinkedIn. If you're on our email list at prehealthshadowing.com, and our email is info@prehealthshadowing.com, we'll also email you upcoming sessions so you can stay kind of in the loop with that. So you can also follow us on any of our social medias. So thank you for joining today, and please stick around if you have any questions. Myself and the other team members are kind of happy to answer any questions that you might have. We'll probably only stay on for like the next 5 minutes or so and see if there's any questions. If there's not, then I wish you guys luck. Send us any messages if you have any problems or if you cannot take the quiz for any reason. So this is officially over. So anyone that kind of sticks around can ask questions. Happy to answer them. You're welcome.